Margaret is a solicitor of the Supreme Court of New South Wales and the High Court of Australia, having practiced law for over 2 decades. She is also an academic scholar of Medicare and health insurance law, having recently completed a PhD. Well done and congratulations. Welcome to the collegiate community of those of us with those lovely little letters at the front of our names. Margaret has been administering medical billing service since Medicare began and is the founder and co-CEO of global medtech company Synapse Medical. Margaret is considered one of Australia's leading experts on the operation of Medicare and contributes widely to the National Health Forum debate. Over to you, Margaret.
Thank you. Thanks very much, Darius. Thank you, everyone. David, Marianne, can I share my screen? Am I able to do that? Can everyone see my screen?
Yes.
Perfect. Okay. Thanks, everyone. So I've got a few slides here, and I'm just going to fly through them. And it's just wonderful to be here. I'm just going to share some insights about how this Telehealth for the Bush project has been going over the last 7 months. One of the, my background is prior to going off and being a lawyer and doing Medicare and all the things I've ended up doing. Haven't quite worn the floppy hat yet, Darius, but I'm looking forward to my graduation next year. I'll send you a photo. But I'm actually a registered nurse as well. That's how I began my life as a nurse when I was 16 years old as a nurse assistant and became a registered nurse. So I'm still a registered nurse, though non-practicing, and I would be dangerous if you put me near a patient these days. But it does mean that I have that clinical context. So I'm going to be really fast in these couple of slides because I want to land on the last slide to talk about the learnings that we have had from this project, this wonderful project. So Synapse, we're a global medtech organisation, so we do technical solutions to administrative problems, billing, coding, education's a big area where we work in as well. Now I'm out on a mission to teach everyone how to use Medicare correctly. We've got 3 offices around the world, and we do the work that we do in other countries as well, which is very, very interesting. One of the things that's been critical to the Telehealth project is the app that you can see there. So we've got Australia's first and only fully integrated app. It's much more than an app. It's actually a giant machine sits behind that app, which is fully integrated with Medicare and all the private health insurers. So doctors can and other clinicians can bill anywhere and get paid by Medicare and the private health insurers. And what that means for this project is that, for example, this app works offline. So you could be in Gawa community and with your app, and you could be seeing patients and billing with your app, and it works offline. So they can clinicians can bill offline, and when they have connectivity, all the claims will go through to Medicare and money will drop into their bank account. So it's, you know, it's been sort of a decade in the making. We're very proud of it, and it's been critical for this project because the other thing is it's the referral mechanism where we refer. So if a nurse practitioner sees a patient, they bill the patient using that app you see on the screen, and then they will refer the patient to a specialist via that app. And then a specialist somewhere in Australia, their app will go ding, and they'll open it and say, oh, I've got a referral to see a patient in Gawa. Okay, I'll organise an appointment. So I'll talk more about that. The other thing is Medicare is critical to the success of this project, but also the future of this project and telehealth in the bush more broadly. And Medicare is very, very complex. So that's just a little example there from my PhD. Like that a single item number can be subject to over 300 rules. In fact, it's about 500 rules attached to that one item number. And Medicare is getting more and more complex all the time. And the federal government is chasing recoveries from incorrect Medicare billing all the time. So what's really important and where we are able to help the participants in this program is to make sure they're billing correctly and help them understand how to bill. So we do a lot of education. Pre-COVID telehealth, so a lot of you would know that there's specialist telehealth has been around for years. So it was designed, the original pre-COVID telehealth was intended to provide specialist care to remote communities, and it didn't work. And the question is, why is that? And I think that we as a group are realizing why it didn't work. And it was largely because of this lack of collaboration and business models and understanding how we all needed to work together to make it happen. So with Marianne and David Simbani, it's just been really an exciting project to work on. It all came out of a conversation one day where someone said that they had a friend who needed to see a doctor. And I think it was the nurse in me who just said, oh, for God's sake, I'll get you a doctor tonight. What is the problem? We will get you a doctor. I've got roughly 1,000 specialist doctors who are clients. I've got nurse practitioners and GPs as well, but 99% of our clients are specialist medical practitioners all over Australia because they use our billing service. So we've got them everywhere. And I said, look, I'll just get you a doctor. So we just got them a doctor and it worked. They got treated. And we thought, let's roll this out more broadly. We have to use nurse practitioners at the moment because of Medicare barriers to general practitioners, but nurse practitioners and general practitioners, I just want to really reinforce, they're both very, very important in this project, and we are not favouring one over another. We are actually saying if you can get to your GP, go there. That's your entry point to the health system. But as we know, for remote communities, that is not always possible. So we set up this program with Marianne and Dave, and we've seen 38 patients. And basically, if you can't access a GP, you jump online, fill out a form, we get a nurse practitioner to have a consult, we refer them to specialists. And in answer to one of the questions in the chat, yes, very bespoke specialists. I've got access to the transplant team at St Vincent's Hospital, Sydney. We've got very, very specialised specialists who are our clients. It's not a problem. We've got the specialists. What we need is the models of care and the pathways. That's what's all a little more complex. But the very exciting thing, I think, for everyone is that all the specialists who are participating in this project, because it's coming through Synapse, through our company and through our app, so we can actually control and see what they're billing, they all have to agree to bulk bill. And they're all agreeing to do that. Now, it's not so easy for nurse practitioners, but that's usually the biggest impost, the biggest cost for patients is the specialist consult. That can break the bank because they're very expensive, but they've got access to the pre-COVID telehealth item numbers, and they're actually quite high paying item numbers. So the specialists are actually fine with bulk billing, which is wonderful. And we're also getting people operated on in hospitals. We've done all sorts of interesting things over the last 7 months. So I'm just going to land on this final slide. I think what we've learned over the 38 patients that we've treated so far is that we talk about patient-centered care a lot, and I'm not sure that we all really understand what that means, or we all at least have a different perception of what that means, because I've certainly learned a lot coordinating the patients. So breaking traditional models of health service delivery is really, really hard. So one example is we referred a patient to the nurse practitioner referred the patient to a really experienced rehabilitation physician practicing out of Melbourne, but that a doctor had done some training in Darwin and knew a lot about the Northern Territory ecosystem. And of course, she saw the patient, she did a beautiful consultation with the patient, and then referred the patient up to somewhere that got lost in the public system. And because we're the concierge, so we're like a patient navigator, if you like, we contacted the doctor and said, what happened? And she said, oh, I've referred her off to the something clinic and she'll be seen in the next 18 months. And I had to have a quiet word to this specialist and say, I know you did that. I know that came from a good place. I know you felt you were doing the right thing for that patient, and you probably were in an old-fashioned world, but please don't do that again. Please don't. Tell us what the patient needs and we'll go find it. We don't want her to get lost in the public system.
Ding-a-ling-a-ling-a-ling-a-ling.
Okay, so that's just one example. And the other areas there, I know I can go a tiny bit over, Darius, because the next video you're playing is 5 minutes and you only went for 3 and 20. So I'm going to steal a minute of his. A simple telehealth consult is rarely all that patients need. I think that's been a key learning. They all need more. They need allied health. Some need surgery. They need MRIs. They need x-rays. They need blood tests. As Marianne said, pathology and diagnostic imaging has been a major blocker. Because they just are a bit intransigent about putting results up on My Health Record. We've realised telehealth is not optional in the bush, it's essential. These people need it and they currently are really denied access. We couldn't have done this without putting a full-time staff member on it. It would not have worked without that. These patients would have been lost. Partnerships and collaborations are essential. Continuity of care is critical, but what does it mean? And I go back to the patient-centric model. Patients are telling us they don't want their records held in GP clinics. It's been really interesting. They've been saying, no, I don't want that. I want my records held on the central government's My Health Record. So I want to get services wherever I need them, wherever I can. And when I can get to my GP clinic, my GP can access them from My Health Record. So they want it, but the providers, I think, have been quite slow and a bit resistant to engaging with My Health Record. Funding models are key. We need this to be properly funded, and Medicare, the current barriers in Medicare are not going to make it sustainable, particularly for nurse practitioners, but also for GPs. Okay, that's it from me. Thanks very much, Darius. Back to you.